Good morning, good afternoon, good evening, everyone. This is our third round of holiday Neuro VMR. We had a few weeks ago, we had pre-Christmas, and today we have the last day of 2024. A great way to finish the year, remembering how amazing neurology is, and taking that memory into next year where we will continue to have some Neuro VMRs on the schedule. So it's going to be a great morning today. We have Taimur joining us to present a case, and our star neurologist in training, who's going to be discussing that case with me, and some CP Solvers team members helping us out with teaching points and scribing, etc. So Taimur and A, do you want to introduce yourselves real quickly, and then we'll get into the case?
Hi everyone, I'm Taimur. I'm a third year med student at Des Moines University in Iowa. But actually, right now I'm home for the holidays, right where Dr. Berkowitz is sitting in Marin County, Northern California.
Oh, great. Yes, you're across the on the other side of this bridge. Yeah.
Yeah, exactly.
San Bruno. Good. We're enjoying a beautiful San Francisco day here. I hope you have good weather up there in Marin also.
Yeah, it's beautiful.
Fantastic. Glad to have you. And everyone knows you, but just in case.
Yeah, hi everyone. I'm A. I'm a physician from Burma. It's now working in clinical research at WashU. I just met with Aaron at WashU Neurology Grand Round, so that's amazing. I'll be doing as a discussion today, so yeah, all excited.
Fantastic. And we'll all confirm we are recording, correct, Valeria? We all heard that happen, so we don't get scared later that we forgot. Great. Okay, Taimur, do you want to give us just the chief concern for your patient, just as few words as possible what the chief concern is?
All right, we have a 55-year-old male with lower abdominal pain and vomiting for 1 day.
Abdominal pain and vomiting for 1 day. Just making sure we're at neuro VMR, right? Just making sure. Okay, good. All right, because if we have to think about the 4 quadrants and whatnot, I will sign off. And I saw Robbie lurking in the background, and we'll let him take it from here. Okay, we're going to presume that if an internist is consulting us about abdominal pain and vomiting, they have ruled out GI causes. What do you start thinking about neurologically that could cause abdominal pain and vomiting?
Yeah, we just have one case of acute intermittent porphyria and cancer abdominal pain and all with polyneuropathy. But it's so rare, and that's my first time seeing. Yeah, with abdominal pain and vomiting, I'll be more worried about very emergent causes, like something increased intracranial pressure in the brain. Um, so I would so it's for 1 day actually acute onset. Yeah, that could be anywhere like in the brain with mass effect for the increased intracranial pressure, or it could also be some infection like meningitis, encephalitis. I would be more worried about these emergent causes. Yeah.
Yeah, I think if we'd gotten just vomiting and heard it's a neurology case, right? I agree with you. What causes vomiting from a neurologic perspective? Increased intracranial pressure could do that. Something going on in the cerebellum. We would probably think there would be vertigo and dizziness with that vomiting. One of the described presentations of neuromyelitis optica. We think of the myelitis part and the optica part, but there's the area postrema syndrome as one of 6 presenting syndromes of NMO, where the patient actually presents with acute onset nausea, vomiting, and people go searching for GI causes, and these patients have a little lesion around the 4th ventricle where there's a lot of aquaporin 4, which is what the antibody in NMO is against. What else could migraine can certainly cause vomiting. Usually we'd expect headache with that, although I think there is something described sort of as an abdominal migraine. But when you put the abdominal pain with it, unless the patient is vomiting so much that just sort of their abdominal muscles hurt, nothing really comes up for me in terms of neurology per se. If the patient had this for longer, maybe had some gastroparesis or something like that, or some sort of dysautonomia. Again, not the usual differential diagnosis for abdominal pain that if we started from the medicine side, but presuming that's all excluded, trying to think of what neurologically could do this. This is not a common consult, right? We've ruled out everything GI. Could there be a neurologic cause of this patient's abdominal pain and vomiting? Not a common question for us. So yeah, A and I just went more probably to the vomiting, and thought of some neurologic causes for that. Abdominal pain, I mean, I guess it depends on the type of pain. If it's maybe a more neuropathic pain and it's sort of localized on a particular area of the abdominal wall, maybe you'd think of zoster, which can cause pain before the vesicles erupt, and you can even have zoster sine herpetae, where you have a radiculitis, basically. Actually, I'm not sure if it's a radiculitis or just the findings in the skin, the neuropathic pain in the dermatome without actual vesicles. I'm not sure if that's the root or that's yeah, actually, I'm not sure what underlies that. But we're really grasping at straws, aren't we? This is not something we would usually see as a neurology consult, so we appreciate that, Timur. Maybe we'll hear a little more history, and then before we go too deep, trying to make connections that might not be relevant here.
Okay. Our patient was febrile, hypertensive, and tachycardic in the ED. He denied chest pain, shortness of breath, or diarrhea. He was generally ill appearing, but answering questions appropriately. He had diffuse abdominal pain to palpation and a distended bladder. He remained in the fetal position during the entirety of the exam, but had an otherwise unremarkable initial examination. Past medical history includes suicide attempt, depression, anxiety, polysubstance use, chronic lower back pain, left-sided craniofacial trauma secondary to a self-inflicted gunshot wound. No pertinent family history. Social history includes polysubstance use of benzodiazepines, cocaine, and THC. Current medications include Seroquel 300 milligrams and Trazodone 200 milligrams.
Okay, and then the patient was well, Timur, until a day ago. Was totally fine?
Yeah, he was well until, yeah, exactly one day.
Okay, and this all started over the course of the day of presentation. Okay, what do you do with all this?
Yeah, he has a lot of like previous history with substance use and that psychiatric drugs. I'm not quite familiar with that, but with fever and hypertension, yeah, I will be more worried about, is there any systemic infections or just infection spreading to the brain and meninges, or is that yeah, maybe he has some he also has a history of trauma, so is that also like something infections going around and then just spreading to the brain or something like that?
Yeah, interesting thought. There's this craniofacial trauma. Is there some abnormal connection that shouldn't be there between the outside world, the sinuses or something like that, and the inside world that could make the patient susceptible to a meningitis or encephalitis? We're not really hearing about confusion or headache to go along with those, but I like the connection that you made. Things that jumped out to me that are maybe shifting my thinking a little bit on this case are the distended bladder and all of these substances and suicide attempts. Any possibilities come up for you related to those, A? The distended bladder or the medications and
Hey, I think you're muted.
oh, sorry, I wasn't sure if you were still thinking or muted, A.
Oh yeah, I was talking,
You have
sorry.
brilliant thoughts. Please tell us again. I couldn't see your mouth because your name is covering it, so I
Oh,
didn't know if you were just still thinking. Yeah.
yeah. Yeah, it could be distended bladder, could be due to any medications, but I'm also concerned with, is there any spinal cord involvement, or maybe there is like increased ventricles enlargements with like incontinence or bladder involvement.
Yeah. Yeah. So when I first heard, before we got to all the social history and past medical history, I thought, oh, there's a distended bladder here causing the abdominal pain. That was a couple of leaps for us. We didn't get there from the initial, what else could cause abdominal pain from a neurologic perspective? We would have had to make several leaps. So what if there's a spinal cord problem or a cauda equina problem causing urinary retention, causing bladder distension, causing abdominal pain? That would have been several leaps. Okay, so there's the distended bladder, and right, I would have thought, you know, either acute cord, you get spinal shock, or cauda equina. So cauda equina, the lower motor neurons, S2 through 4, are the parasympathetic to the bladder that tell it to contract and pass urine. So if the parasympathetic is blocked, so if you block the cauda equina, then you can't pass the parasympathetic signals and the bladder distends. The spinal cord, chronically, for example, in patients with chronic spinal cord problems after trauma or after or patients with longstanding multiple sclerosis affecting the cord, you can get the spastic bladder, sort of upper motor neuron hyperactive bladder. But in the acute setting, and this is an acute problem, acute spinal cord injury or transverse myelitis, it looks like the lower motor neuron pattern, just as it does in the limbs. You have sort of flaccid spinal shock at the beginning, so you could get bladder distension. So I was with you there, and then I saw these medications and substances and wondered, is this some toxic effect of medications either prescribed or not prescribed that's causing this bladder distension? And when the bladder is distended, you can get these sort of hypertensive tachycardic when you can't control the bladder. There's some sort of associated dysautonomia. I don't fully understand this, and I don't know if it's only in patients in whom that's from spinal cord trauma. I remember learning this as a resident, that we had a patient with prior spinal cord trauma who kept having these sort of spells of hypertension, tachycardia, and I think it was a physical medicine and rehabilitation consultant who said this is very common in patients. It's sort of the signal, since you can't feel your bladder, that the bladder is distended and needs to be catheterized if the patient can't pass urine spontaneously. So that could be one relationship between those two, or maybe this whole thing is some kind of dysautonomic presentation from something we didn't think about with the initial chief concern, which is some type of toxic effect. What toxin exactly? Hard to know, because the patient has a history of substance use and maybe taking things that are not on the medication list, or getting drugs without knowing exactly what is in the drug or what they may be laced or mixed with. So this could all be some type of drug effect. The patient is on Seroquel, Trazodone, overdoses with either of those. I don't know about bladder distension. Don't know if you could get serotonin syndrome with an overdose of the combination of those two. I don't think I've ever seen serotonin syndrome. That's something we all learn about not missing. I don't think it's supposed to cause bladder, kind of a hyperadrenergic, opsoclonus, nystagmus, hyperreflexia, all that kind of stuff. So maybe we'll hear about some of that. But I think this is starting to look more to me like some type of toxidrome. What do you think, A?
Yeah, I also think like that, mostly toxic metabolic, but I'm really not familiar with these antipsychotic drugs.
Yeah. Seroquel, right, is antipsychotic. I don't know if it has any serotonergic activity. It has that sero in it that always makes me think it's a serotonergic drug, but it's quetiapine. I think it's more dopamine. Someone can fact check me and tell us in the chat. And trazodone, I think, has some serotonergic activity as well. But someone can double check. I'm not sure. So yeah, this is starting to feel a little bit more like a toxidrome, and I think the fever even could still be part of that. So what else would we find on exam? The vital signs. With serotonin syndrome, like I said, there's, I think, opsoclonus or nystagmus, so rapid fluttering eye movements of various types, hyperreflexia, and kind of tachycardia. This is often taught in the context of distinguishing it from neuroleptic malignant syndrome from antipsychotic or antidopaminergic effects, or can also be caused by withdrawal of dopamine agents in patients with Parkinson's if it's rapidly withdrawn. Also something I'm not sure I've ever seen, but similar kind of hyperadrenergic state plus in those cases, instead of hyperreflexia, I think you're supposed to get rigidity, as would make sense with the paucity of dopamine. Okay, so I'm thinking we're going to examine this patient, look for whether there's any clues to a toxidrome, maybe sending a tox screen. I'm starting to get anchored in that direction, giving the past medical history and social history. Anything else we should keep in mind to keep things broad, A? Starting to think that this is some type of substance toxic related thing. Anything else we should, you mentioned the possibility of a neurologic infection, so maybe we'll look for meningismus, we'll assess the patient's mental status. Not sure how we'd fit distended bladder with that. Anything else you'd be thinking of?
No, not really. Yeah, that's all I would be thinking. Like with encephalitis, infections, encephalitis, meningitis, and also some sort of inflammatory process, autoimmune in the spinal cord, or yeah, just toxic metabolic.
Yeah, good thoughts. It's easy to get anchored with all this context, right? And it's always important to ask yourself, okay, this context is sort of framing me that I'm worried about a toxidrome. There's lots of potential toxic exposures here, both on the medication list and knowing there's a history of substance use disorder. And what would I think if this patient had no history of any of those things? We'd still have to think about it, right? Because it's possible, but we might wonder, as you said, about some type of transverse myelitis or something like that. So to get all that dysautonomia from the beginning, not sure. But yeah, we want to keep broad because the context is not always relevant the way it would be in a USMLE question. Okay, Timur, you've got us thinking about things we don't usually think about here, so we appreciate that. We're usually trying to find the anatomical localization, and so far we have not talked too much about anatomy at all. So we're thinking outside our usual box, which is always a good exercise. Okay, what did you and your colleagues find on the exam?
Okay, moving on to our exam. 9 hours after admission, the patient was only intermittently participating in history, talking with volitional, affirmatory groans in response to questions. Nursing reported he was able to stand at bedside to urinate without assistance. He did not cooperate with any testing. He was able to endorse abdominal pain, but otherwise had an unremarkable review of symptoms. On physical examination, he lay restless in the fetal position, spontaneously moving all extremities with his eyes closed on the bed. Bladder was palpated at the level of the umbilicus. He had no abdominal tenderness, guarding, or rebound tenderness. He did endorse moderate L3 tenderness to palpation, but otherwise no spinal tenderness. He was unable to participate in a thorough neurological examination, but could move all extremities when asked, and had reduced grip strength bilaterally. Pupils were equal, round, and reactive to light. He had no track marks or rashes present anywhere on his body. Cardiac exam revealed tachycardia with no murmurs. Lungs were clear to auscultation bilaterally.
Okay, A. That's all we've got from Timur. He's challenging us today on the last day of the year. But this is a very common scenario, right? We'd like to get our neurologic examination and the patient may not be able to participate. Just to understand, Timur, you said he was responding only with kind of groans. Was the sense here that he was somnolent, or the sense here that he was confused, or sense he was just in so much pain that he didn't want to participate? Can we get some sense?
Yeah, I would say he was somnolent.
He was somnolent.
But essentially able to respond to questions with an affirmatory groan, yes, or would stay silent if it was a no.
Okay. And to the best you can tell, there was no obvious vocality, just watching the patient move spontaneously, but obviously we're not able to get our detailed exam here. Okay,
Yeah, he was able to move all extremities while on the bed.
On the bed. Okay. So nothing focal and then sort of somnolent, but maybe when you wake him up, he's in there, as I like to say. He's in there. He can kind of
Exactly
respond, just not just as any of us would do in our profession, where we're often falling asleep or about to fall asleep, maybe just some groans as we're drifting off into sleep. Okay. And then some spine tenderness. Yeah, very common scenario, right, A, for us in neurology, that were called, in fact, because the patient can't really participate in the exam, and is there a neurologic cause here? So what's your approach here when you have a concerning sort of history, and then the exam, we can't really do our thing, right? And get a lot of detail here, aside from equal and reactive pupils and no gross motor deficits and sort of somnolent, but can't really access the patient's mental status in detail. How do you approach evaluating these patients?
Yeah, it's kind of like having our good approach with that altered status approach. The patient is somnolent but no focal deficit. So for altered status, that could be like metabolic toxic, like affecting the brain, or like infections in the brain itself, having encephalitis, or could be due to other structural causes in the brain, like hemorrhage or like SDH. And then, yeah, toxic metabolic. It's hard to tell, as there is, or we cannot find any focal deficits. Yeah, the limbs are moving, but so we couldn't tell there is actual weakness or not. But I think he said there is reduced grip bilaterally. So I'm not quite sure there is any focal localization we could make for that or not.
Yeah, I agree. This is a tough one, right? And sometimes we just can't get a clear exam, and we're left with maybe doing more testing than we would have done if we had been able to get a full exam and either rule in or rule out some things based on what we found. The pupils being equal and reactive probably excludes some toxidromes, but not all of them. I don't think serotonin syndrome or neuroleptic malignant syndrome, not that the latter is on the table, but maybe the former at one point at least was. I don't think that affects the pupil. Yeah, it doesn't affect the pupils. The bladder retention, we could have thought of something anticholinergic. That would usually give you large pupils, again, knocking out parasympathetic, sympathetic winds. It's probably not that chemical in the brew here, in the toxic brew of whatever could be going on. And then probably unexplained is that tenderness at L3. Again, if we remove the context, does this patient have a spinal epidural abscess? Bladder retention without any motor, although we can't really tell if maybe he's a little weak. So I think, as you said from the beginning, a spine remains in play. We don't see any track marks. Timur told us we don't know if there is a history of IV drug use. That could predispose to an epidural abscess, to a spinal infarct. There is, I've never seen this, but I read about it because I was writing a review on toxic myelopathies with a colleague. There is a heroin-associated myelopathy where usually the patient has abstained from heroin for some time. They've used it a lot. They've abstained either voluntarily, or many of the cases reported patients have been imprisoned for related to the drug possession. And so they don't have access to heroin. And then when they use it for the first time again after this period of abstinence, they develop an acute myelopathy. It's not clear what causes it, whether it's some toxic component of the heroin or whether it's the patient is sort of hypotensive from overdose and infarcts the cord. I don't know if they would have pain with that. So all that to say, spine is still in play and some type of toxidrome here, and then the tenderness might be a red herring or not related. So we're kind of stuck with a lot of ideas and not a lot of exam to guide us. So we probably end up doing more testing. As I mentioned, what tests would you start getting here to try to tease this apart?
Yeah, I would like imaging, like MRI, spine and brain.
Yeah.
Yes.
So, right. So I think the spine is at play. Ideally, if we can get a better exam, we like to try to image one or two parts of the spinal cord, because if you get a whole spine MRI, it's sort of a lower resolution kind of cord compression type sequence that looks at the whole spine quickly. And if you order a C-spine MRI, T-spine MRI, and L-spine MRI, all three, that's a very long study. The patient will start to move and you'll get bad results. But in this case, the patient's probably not going to be super cooperative and lie still given the pain and not really participating, and the spine is at play. So I agree, probably get the whole spine. And then you start to say, well, he might be confused under there and he's already going into the magnet. Should we just get the brain? You feel like, oh goodness, would like to use my exam, but instead I'm just getting an MRI of the whole neuraxis. But sometimes in these cases that's needed. Or if the patient had come in and already had a CT head before you saw them and there's nothing there, maybe you feel comfortable just getting the spine. So yeah, I would probably look at the spine. We're going to get some basic labs and see if there's signal for infection, and then a tox screen. That would probably be my first pass. There's this tachycardia, so presumably our medicine colleagues have gotten an EKG, see if there's any actual arrhythmia or just change in rate, and whether that arrhythmia could give us a clue to some toxidrome of some sort. Okay, so basic labs, a tox screen, some imaging of the spine. Do we think we're going to find anything, A? Is this going to end up being toxic metabolic, or do we think this is going to be a spinal cord thing in a patient who happens to have a history of drug use?
Yeah, I also have some bias, like I'm a little more like leaning on spinal cord.
Yeah. Okay, well, good to acknowledge our biases. Yeah. I don't know. I would certainly work this patient up for all the things we've talked about. So do I think we're going to find something in the spine, or is this ultimately going to be toxic, or is it ultimately going to be both? I'm not sure. I would say before the exam, I thought this was going to be toxic metabolic, and after the exam, I kind of still thought that, but I think I'm having morning report bias that it might be two things or something unexpected. Okay, Tamor, what did you and your colleagues think at this stage, and then what did you end up doing?
Okay, I actually, just to talk about what you guys are speaking on, that this was our exact differential at this point. Leaning spinal epidural abscess, or a toxic exposure that was causing this distension and fever, tachycardia. So I think we also had some suspicion for endocarditis, given our patient's kind of infectious presentation and history of drug use. So that was one differential we had as well.
Yeah, so maybe throw blood cultures on those labs. Yeah, could he have endocarditis? The whole thing is pretty sudden in onset, and maybe through some septic emboli to the cord or to the brain or both. Great thoughts. Okay, what did you find in your workup?
All right, so I'll give you some of the stuff that you guys talked about. So our laboratory evaluation was significant for white blood cells at 30.5, lactic acid of 3.9, CMP showed a calcium of 8.2, albumin of 3.3, sodium of 135, carbon dioxide of 13. Toxicology screen was positive for benzodiazepines, THC, and cocaine. Respiratory panel and COVID-19 testing were negative. CT of the abdomen and pelvis revealed bilateral hydroureter, moderate distension of the bladder, and a moderate volume of rectal stool. Subsequent urinalysis was unremarkable for urinary tract infection. His bladder was decompressed with a Foley catheter. The patient was started on piperacillin, tazobactam, vancomycin, and doxycycline for empiric treatment of systemic infection. Ethylene glycol and alcohol panels were negative. Acetaminophen and salicylate panels were negative. On repeat labs the following day, white blood cell count was 18.6 and lactic acid had dropped to 1.4. Blood cultures drawn at the ED have come back positive for strep pneumo.
Okay. Hey, what do you make of all this?
Yeah, it has high white blood cell counts, and is that albumin 3.3 is like low albumin?
I think that's a little low. Yeah, I don't look at albumin too much. Yeah.
Yeah, and then they started antibiotics, and then white blood cell counts also getting low, and lactic acid also getting low. And I think it could also be like infections, but even after antibiotics, the white blood cells stay high and albumin is a little low. Is there any inflammatory or is there any other like inflammatory or autoimmune processes? Kind of like AIDP or Guillain-Barré, like and for the bladder distension, it have bilateral hydronephrosis and things, but it couldn't be due to UTI. So I'm more worried. Is there a problem from the spinal cord involving the bladder? So,
Yeah, and
yeah.
what do you do with the positive blood culture for strep pneumo?
Oh, right. Positive blood cultures for strep pneumo. So yeah, I would be also more worried about like abscess spinal in the spinal cord, or is that just separate issues?
Yeah, so it sounds like the tox screen was not too revealing. These are things we know the patient to take. This might not be an extended tox for things like SSRIs and those other things. Hypertension, tachycardia could be caused by cocaine. I don't think any of this urinary retention should be caused by benzos, THC, or cocaine. So probably, even though that was, we thought, part of the picture, doesn't explain the whole thing. And so now we have the strep pneumo. We've been thinking about the spine. As you said, is there an epidural abscess? As Tamor said, is there endocarditis with some septic emboli maybe to the brain and cord? What else could we think about here? Yeah, I'm not sure too much what to do with strep pneumo. He does have this consolidation in the right upper lobe. There is this, it's Austrian syndrome, after somebody named Austrian, not after the country Austria, which is strep pneumo, endocarditis, pneumonia, and meningitis all together. We didn't hear about meningismus or headache here. Probably meningitis of the brain at least wouldn't explain what's going on, what we think in the spine, but that's a triad with an eponym: Austrian syndrome, strep pneumo, pneumonia, endocarditis, and meningitis together. All right, well, obviously we have to treat the infection, and then we want to sort of see where the neurology is and whether we need more, because if there's an epidural abscess here and it's large, it may need to be drained. We presume there's strep pneumo in there, but it could be polymicrobial, and that might change our antibiotic management. Okay, so probably as you asked for, we want to take a look at the spine. Some people might be wondering, well, we thought of meningitis, should we do a lumbar puncture? Well, we have epidural abscess on the table, right? So we don't want to be putting a needle through an epidural abscess and making that epidural abscess purulent material find its way into the CNS. That would be a very bad situation. So we probably want to look at the spine first. If somehow the spine is clean here, which seems improbable, but I guess is still possible, then we'll want to rethink things a little bit. Okay, so I'm going to guess, as A had requested for a long time now, Tamor, that you and your team were curious to take some pictures of the spine. But what were you thinking at this stage related to the strep pneumo and the whole presentation and what happened next?
Yeah, I think that particular bacteria was kind of interesting to us. And I guess we were also kind of trying to think of the etiology of how this patient got particularly a strep pneumo bacteremia and where it was localizing. I think we were right on the same page thinking spinal epidural abscess as our main culprit at this point.
Okay, so you took some pictures, and did you find one?
Well, let's see. I have 2 aliquots left, I think.
Okay.
Or I can read them the whole way through.
Read us the first one, and then we'll decide.
Okay, sounds good. Okay. CT of the head showed new complete opacification of the left tympanic and mastoid cavities, but was otherwise unremarkable. Subsequent physical examination of the patient revealed no mastoid tenderness, excessive warmth, or erythema, but the left ear canal had been surgically closed after prior cranial surgery. Echocardiogram showed mild aortic regurgitation with an ejection fraction of 65 to 70% and no evidence of valvular vegetations. And then I guess I'll prompt you guys what final test you'd want to get before our diagnosis reveal, but I think you had already gotten there.
Yeah. Anything you would do with the CT head findings, A?
Yeah, it is complete opacification of left tympanic and mastoid cavities. And yeah, I don't know much about it. Like, is there, oh, okay, is there any infection like abscess or yeah, just like kind of abscess? I don't know much about it.
Yeah, great. So yeah, this is Tamor said new means maybe the patient had a CT before where this wasn't there. You had mentioned earlier, A, that given this prior facial trauma, the patient may have some type of abnormal connection between the sinuses and the brain, which could put them at risk for meningitis. So maybe that's the source here. Maybe this patient has sinusitis becoming meningitis, and maybe you can get spinal meningitis also, where the meninges surrounding the spinal cord are involved. Strep pneumo in there, I'm actually not sure what bug you tend to get, which group of strep you tend to get from the mastoid. But I think you had that idea earlier, and that's certainly at play here. And yet, I don't think mastoid opacification, right, as you said, explains urinary retention, and so we're still interested in the spine. So I guess if we're trying to put it all together, A, you've been interested in the spine and the possibility of epidural abscess with strep pneumo. The patient doesn't really have endocarditis on the transthoracic echocardiogram, but that's not completely sensitive for vegetation and may need a transesophageal echocardiogram. Or if the valvular function is normal, that may be moot. We already know the patient is bacteremic, seems to have some related neurology. We treat the bug that's growing in the blood and then see if there's a need for any type of surgical intervention if there's an abscess in a particular place. Okay, so I think, Tamor, we want that spine MRI for a while now. You've given us a lot of good medical information. We're always interested in our neurology tests. Is that what happened next? And what did you find?
That's exactly what happened. Okay, on day 3, our patient was then alert and oriented enough to perform an MRI of the head, cervical, thoracic, and lumbar spine without need for sedation. MRI showed findings concerning for spinal meningitis and arachnoiditis. Lumbar puncture culture came back positive for pneumococcal meningitis, and intravenous ceftriaxone therapy was begun. After chart review for this patient, we found that he had been receiving frequent lower back injections to treat pain caused by a car crash years prior. The patient had some persistent left lower extremity weakness during his stay at the hospital and was working with physical therapy to regain independent mobility.
Okay, so interesting. I had just mentioned this possibility of spinal meningitis and arachnoiditis. We don't usually think of that with bacterial meningitis. People talk about it with tuberculosis and maybe more chronic meningitis. I think maybe even syphilis, but I'm actually not sure. So presumably saw enhancement of the meninges here from the top to the bottom, and nothing in the parenchyma, right, Tamor? The brain was clean, no strokes. The spinal cord was clean, no infarcts.
Yeah,
Right.
brain was completely clean. It was just that, spinal meningitis and arachnoiditis they saw.
Meningeal enhancement. Okay. I think it's one of the first things you said, just from vomiting, abdominal pain. You said, could this be, if it's neurologic, could it be meningitis? And so did the patient ever have a headache, Tamor, or when they were well enough, they were able to tell us whether a headache had ever been part of this? Or
He did, but basically only after he had been receiving intravenous antibiotics for a few days. He slowly became able to answer questions, and we interviewed him a little more thoroughly, but
Yeah.
Yeah. He really presented to the ED exclusively with abdominal pain. That was
Yeah.
why we were called down.
Yeah. Well, great case. We have a little time to debrief on it a little bit. Right. So the patient did have a headache, but couldn't tell you. So there's a paper, many of us here probably love these JAMA Rational Clinical Exam Series papers. Does my patient have ascites? Does my patient have this? There is one, does my patient have meningitis? And the triad of, headache, neck stiffness, fever, or headache, neck stiffness, fever, altered mental status, whatever the classic triad, tetrad is, has very poor sensitivity. And so you don't always have a headache, you don't always have a fever, you don't always have neck stiffness. When meningitis was described, however many hundreds of years ago, patients were coming in very late, right? And by that time, they have Koenig and Brzezinski signs and all these things we learn about in school and for exams. But unless you're working in a very resource-limited setting where patients come very late, it's actually not that common to see Koenig and Brzezinski sign. In that paper, I saw someone just put it in the chat, thank you. That paper shows that they have something like 5% sensitivity or something. So even though this patient had a headache, they couldn't tell us. And then even if they hadn't had a headache, they still had meningitis. So that's an important point. I definitely recommend people check out that paper. All of those papers sort of kind of show how surprisingly insensitive and non-specific a lot of our classic triads, tetrads, pentets, etc. are. Okay. Any thoughts, reflections here, on this case? You kind of intuited it from the beginning and stuck with it throughout. I got distracted by toxins and drugs, but we kept coming back to the spine also. What are your thoughts here, concluding thoughts, or any teaching you have for us on spinal meningitis?
Yeah, this is really fascinating case. We first thought that could be just something with toxic metabolic. And then that's kind of case I want to present, because we have all we have to think all of these like neuro syndromes with the brain, like automated status, and then there are like fevers and pain. Like sometimes I just present a case like peripheral nerve or things like that. But yeah, this is kind of like case I want to present. I haven't quite seen like spinal meningitis, but yeah, this is really fascinating. I really enjoy having a discussion.
Yeah, I'm trying to remember if I think maybe I've seen one case of known bacterial meningitis, and the patient was very confused. I might be conflating a few cases here. And as the patient was improved enough to participate in the exam, we found that she was weak and realized there was either spinal meningitis or spinal meningitis with resultant infectious vasculitis and a spinal cord infarct. Or I may be conflating this with a case of West Nile virus encephalitis with poliomyelitis, because West Nile virus can get the gray matter of the spinal cord and cause some lower motor neuron problems. And maybe I'm thinking of a particular case, or maybe two cases from a long time ago. But yeah, the meninges, remember, extend to wrap around the entire central nervous system. So you have meninges down there around the spinal cord. And when you do a lumbar puncture, you are going through the meninges, right, to get into the CSF compartment. Okay, Timur, any teaching points you brought for us, or things you wanted us to take away from things you learned
absolutely.
about meningitis?
I think one interesting point that we got from the infectious disease doc who's working on this case as well was, it was exactly what you said earlier, was that his thought was that this prior craniofacial trauma had kind of compromised the meninges, and, this, chronic sinusitis of his left mastoid cavity had spread to the spinal cord, which I don't think we had thought of prior to hearing from ID. And then I think actually one thing I wanted to get your perspective on was that arachnoiditis. From my understanding of looking, it kind of seems that this is a generally chronic process, like adhesions of the spinal nerve roots in the lumbar cistern. And whether you think that might have been from these frequent injections that our patient had been receiving for his low back pain, or was this a secondary to his infection?
Yeah, that's a good question. I'm not sure. Okay, so the meninges are three layers, right? The dura mater, the arachnoid, and the pia mater. The dura mater is sometimes referred to as the pachymeninges. Pachyderm for elephants is the thick meninges, and then arachnoid and pia together as the leptomeninges. So the arachnoid is part of the leptomeninges. I'm not sure if just the way the radiologist described it here meant that there was leptomeningeal enhancement, and they just called it meningitis arachnoiditis. You're right, you can get a chronic arachnoiditis from sarcoid, I believe, from tuberculosis, from sort of chronic injections back there. The injections in a pain clinic should not be getting into I'm pretty sure should not be getting into the subarachnoid space. They should be kind of epidural injections. I believe, I could be wrong about that. I don't think you should get arachnoiditis from that. You can get a chemical arachnoiditis, for example, after a contrast myelogram, I believe. So yeah, I'm not sure arachnoiditis itself implies a time course, as you asked, but I'm not sure I've ever thought about it. So I like these questions I haven't quite thought about them. I wonder if the radiologist is trying to say here the meninges are inflamed. I just saw Robbie's question fly by. Why is a patient having urinary retention? If the arachnoiditis meningitis is extending to the cauda equina, I guess here, and maybe was there enhancement of the nerve roots, Timur? Enhancement of the cauda equina nerve roots? Do you know?
I cannot quite remember. I'm sorry.
No problem. Yeah, so probably just dysfunction of the cauda equina, Robbie, I would guess. Or MRI of the spine is not that sensitive for infarction, and if the patient has very severe meningitis, arachnoiditis, then the vessels that pass through the meninges could be inflamed due to secondary vasculitis and could have some cord infarction, though it sounds like the patient was improving well, make that a little less likely. But yeah, even DWI that we use in the brain, this MRI sequence for acute ischemia, it's not great in the spine, in part because the cord is so small. Every time the patient breathes, the cord moves. So that's my best guess. I don't know if you wanted to unmute Robbie and tell us more what you were thinking. I'm not sure where you are, if you're in transit or seeing patients at the same time. But I'm guessing, yeah, you were wondering if the cord parenchyma is okay, why is the patient having these problems? And I would guess it's dysfunction of the cauda equina nerve roots that are inflamed from this infection, would be my guess. Okay. Any other thoughts, questions, perspectives? And it was just good old-fashioned strep pneumo, Timur, is that right? No funny bugs or?
Yeah, just strep pneumo. That was the only thing that came out back on CSF and blood cultures.
Yeah, I shouldn't say just, right? This strep pneumo can cause very severe infection. But I'm remembering one case as a resident where a patient had pretty classic meningitis and had a kind of atypical strep grew in the CSF. Maybe it was a group D strep or something. I was a junior resident. I remember we thought, okay. They were treated. And then they came back to the ED, I forget why. And the ED resident noticed that they were having some clear fluid from their nose and wondered if they had a CSF leak, which was a brilliant thought. And you can send, what is it, a CSF? Oh my goodness, I haven't sent this in ages. Is it a CSF transferrin or something? Someone can, to check if it's CSF or mucus. And then my mentor, Marty Samuel, said the cheaper way to do it is have the patient hold a tissue to the secretion. And if you have a runny nose and you blow your nose and you leave the tissue out, it gets hard. That mucus will get hard, and CSF, it will not harden the tissue. Is it a CSF? Thank you, beta transferrin. Yeah, I knew it was something transferrin. Right, and glucose, great thought. Thank you, Anise. Right, CSF has glucose in it, unless the patient has very severe meningitis. In this patient, that might not work, whereas mucus does not if you don't have this beta transferrin, and I don't know how quickly it comes back. So that patient, by discovering an atypical bug, we should have thought and didn't realize this patient has some atypical passage from the oropharynx or sinuses into the brain. And that patient had a prior car accident and unknown to her had a CSF leak and just thought, you know, had allergies or something like that. Okay, fantastic, great case, Tamor. Very kind of unique case. I think we spend a lot of time talking about localization, which we all love, or sort of more bread and butter stroke, seizure, or kind of rare zebra-y kinds of things here. And this is a kind of bread and butter diagnosis, but presenting a kind of atypical way with a very good chance to try to think about the neurology when there's not a neurologic chief complaint or history, and where we can't really get an exam. And kudos to A, who just from wonderful intuition said, well, it's abdominal pain, vomiting, and it's neurology. Could it be meningitis? Said the diagnosis from the beginning. And we knew meningitis and spine, and we thought abscess, but in this case, spinal meningitis. So good to know about that. Fantastic. Okay, well, what a wonderful 2024 it has been with all of you talking about neurology, our beloved specialty. And big thanks to A and Valeria and Team Neuro who have been putting these sessions together. And big thanks to Tamor for presenting, I think, your first case here. Very interesting case, led to a very interesting discussion. And clearly you and your team did some hard work here to get to a diagnosis of spinal meningitis from vomiting and abdominal pain, which is quite a journey here. So wish everyone a wonderful holiday season here. Happy New Year, and more great neurology to come together in 2025. Happy New Year, everyone. Thank you.